I'm Laura Bonnell, and this is the Living with Cystic Fibrosis podcast coming to you from Detroit. Please subscribe and even rate and comment on our podcasts when it moves you. I learn something new with every podcast, and I'm always inspired by the people that are showcased here. We don't give medical advice. You need to connect with your doctor for that. I hope that this Living with Cystic Fibrosis podcast educates you and sparks some volunteering or advocacy. The CF community needs people like you. Thanks to our sponsors, Viatris and Vertex, for their support. Dr. Wendy Chung is a clinical and molecular geneticist, and she is Chief of Pediatrics at Boston Children's Hospital. And Mary Ellen Avery Professor at Harvard Medical School. She leads NIH-funded research on genetics of conditions including pulmonary hypertension, autism, birth defects, and rare diseases, and has advanced newborn screening for disorders like spinal, muscular atrophy, and Duchenne muscular dystrophy. A national leader of ethics and genomics, Dr. Chung has received the Rare Impact Award from NORD and is a member of the National Academy of Medicine. And I read about her in the Rare Revolution magazine, and I picked her story up from there. Dr. Chung wrote about the triple threat to the rare disease ecosystem, and that's exactly what we're going to talk about right now. And thanks for joining us, Dr. Wendy Chung. Really appreciate having you. And there is so much misinformation and poor leadership out there coming at health and science, as you are very aware, because it's almost difficult to figure out where to begin. But as I said in your introduction, you did this fantastic piece in that Rare magazine, and that really caught my attention. And so I wanted to talk about who you are and what you're doing to raise awareness about concerns we should all have. And you wrote about 3 areas of concerns: research, investment, healthcare access, and educational support. But first, I just want to say welcome.
Thank you. I'm thrilled to be here.
Thanks. And do you kind of want to start us on those 3 things and, what you've been seeing? Thanks.
Sure. To let you know who I am so you understand the source of the information, I'm a physician scientist. I'm trained as a pediatrician and a geneticist. And because of being a geneticist, most of the patients that I diagnose ultimately are diagnosed with a rare genetic condition. One of my points is that this was a piece that was in Rare Revolution. Most genetic conditions are rare, and so the resources sometimes are scant. And as we think about this, it's trying to think about positioning to make sure that our communities, our individuals affected, are not left behind. And part of that is because even though conditions are individually rare, they're collectively quite common. So with 7,000 rare genetic conditions, each one might be 1 in a million or 1 in 10,000. But when you put them all together, it's actually about 10% of the population. So many individuals are not diagnosed, and that's terrible because some of them have treatments, and like cystic fibrosis has incredibly effective treatment for most, not all, but most individuals. And so we want to make sure the right person gets the right treatment at the right time when it can actually be most effective. So the concern is that I actually have had just awe, I will say, for the cystic fibrosis community in terms of how visionary, how well organized, how strategic it's been in terms of moving things forward. And I actually hold up the CF Foundation to many of my other rare disease groups as a playbook in terms of how you can move things forward. But if you look back, it was not always this way. When I was a resident first in training, literally my cystic fibrosis patients, many of them didn't live to be adults, didn't live to grow up and get married or have families or have children. I mean, it was just a completely different world. Mm-hmm. But to get to the point of the medications that we now have, which really are transformational, it took an enormous amount of basic science to be able to, number 1, identify the gene, number 2, understand what the gene did and that different mutations in the gene did different things, to be able to have models, to be able to test different types of medications, and then ultimately to develop and test those medications. I mean, that was decades worth of work. all of that basic research, very basic research, was done at universities, at what we call academic medical centers, and it took funding from the Cystic Fibrosis Foundation, from the federal government, and some of that work we didn't know what was going to ultimately be critical for treatment. We just had to understand the condition and the mechanism. Without that investment in basic research, the ultimate sort of foundation that you need for information to develop therapies is oftentimes missing. And so I worry about communities that won't have access to those treatments. The other part is that those academic medical centers are also where we train the next generation of physicians and scientists to be able to provide care, oftentimes cutting edge care, and to be able to advance the research that goes towards improved care and cures. And with that, if we don't have that next generation to go forward, we won't have the great doctors that take care of us and have that real clinical intuition to know when we need to make adjustments to treatment or when there are gaps in the treatment that we may need to sort of improve and iteratively make better. The other part of this is that, and again, as a pediatrician especially, becomes access to the healthcare. So once we have treatments, once we have good ways of being able to support individuals, how do we make sure they can actually access that care? And for children, as an example, 1 in 2 children is on Medicaid. It's not a poor person's health insurance. It's insurance for half of the children in this country. And when it comes to rare diseases, the majority of individuals, both children and adults, actually are on Medicaid or Medicare. And the cuts that are slated, they're actually going to happen after the midterm election, but the cuts that are slated could be devastating for children and patients with rare diseases. So what's really heartbreaking for me is when we spend this decade's worth of time to be able to get to good care and then people can't access that care. It's like, what was the point? That really is, and it's not even. There's certain individuals, and it'll come down to even certain states, because Medicaid is not only a federal, but also to a certain extent governed at the state level. So there are going to be pockets, places where access to care is going to be more or less difficult for individuals. And then I don't know that this, thankfully, is not affecting the cystic fibrosis community as much now, but for many children with neurodevelopmental disorders that are genetic, there are also special educational needs. And just in general, individuals who have disabilities may need special adaptive equipment or accommodations or class settings or other things. But for everyone to realize their full potential, they need to be able to have access to education. And so the third part of this is, things that are happening in the country around the educational system as well, at least at a federal level. So with all of those things, those are the 3 points that I was just bringing out in the article. There are actually subsequently things going on in the FDA and other changes that are coming about, even changes to the newborn screening program, which is how in this day and age, most individuals get diagnosed actually as newborns with cystic fibrosis, and really enables our ability to be able to, like from the first week of life almost, to be able to start them on the right path. All of those programs are in transition and or being defunded and are going to have limitations in terms of what we have heretofore been able to do in the rare disease community. So anyway, those are some of the concerns.
And very important, and I want to talk more about those, but I wanted to ask you 2 things first. One is, what excited you about getting into rare disease or pediatrics? Like, what made you pick what you have chosen?
So in part, I'll be honest, it clicks with me. It's the way my mind works in terms of genetics specifically. It's a very, to me, logical science. And I actually grew up with the genome era. So when the first year of my MD PhD program was the year the Human Genome Project was announced. And so I literally professionally grew up with thinking about this. And luckily, I knew it was something that I could see how, with all of the genetic book of life, so to speak, how you could use that. And as I was thinking about that, this may sound a little bit corny, but I believe I worked very hard, and I wanted to make sure that if I worked hard on something, something was going to come of it. And I thought to myself, if I invest in kids and I can keep them healthy, then they have an entire lifetime ahead of them. So it's a big return on investment, so to speak.
I love that. That's beautiful.
Yeah, that really was in thinking about that, how to give every child a healthy start to life and how to keep them healthy.
And so you really sort of started on that CF track. I mean, when Dr. Francis Collins and Dr. Mitch Drum and all those others were doing that Human Genome Project in 1989, like that was when you started your career. That's amazing.
Yeah.
I mean, that discovery just opened up so many possibilities, right?
Like I said, it really was the trailblazer, I guess is the way I think of it, in terms of everything we've done for genetic rare diseases. I feel like we've had lessons learned from cystic fibrosis, and I feel like it's kind of the big brother, big sister to the rest of the community. And it's filled me with joy, I have to say, in terms of being able to see how far we've come.
And now everybody's talking about newborn screening and genome sequencing. Can you explain that and how it relates or has come from the Human Genome Project?
Sure. So with the Human Genome Project, we can read out the 3 billion base pairs that make up anyone's DNA code. Within this, we don't, I'll be honest, we don't know what it all means. We know what quite a lot of it means, but not all of it. The thing about genome sequencing, so we take, just to explain it, on a newborn baby, we take a few drops of blood from a heel stick and we put it on a filter paper, and that's what we do newborn screening with. And we can measure many different things from that. We can measure certain amino acids that tell us about a condition called phenylketonuria that allows us to change a baby's diet and prevent intellectual disabilities. We can check for cystic fibrosis with a combination of checking something we call immunoreactive trypsinogen, and then sometimes sequencing out the CFTR gene to be able to look for those genetic variants. And that actually was what, in part, started me thinking about this. That is that you could sequence out, you could read out the DNA code for a gene like the gene for cystic fibrosis. And I started to think about this and say, well, that's one condition. Thankfully, it has a treatment and it's one condition. But could you not scale this? And if you could do 1, could you do 2? Could you do 20? Could you do 200? And the real answer is you can do 20,000 if you want to. Now, the problem is right now we don't have treatment for 20,000 conditions, so it's not really appropriate or necessary to read out the DNA code for 20,000. But we do have, say, about 500 treatable conditions. So rather than just screen for a few treatable conditions, let's screen for all of the ones we can, because the sooner we can make those diagnoses, and if we can make sure we don't leave any baby behind, the better the outcomes. That is, even though any one condition is rare, again, collectively they're common. And so if you pool all of those 500 together, maybe you end up, as we're finding, that there are about 3% of those babies that have something. And then that's 3% of babies with a much better outcome in life, a much healthier start to life than if we didn't know the information. So it's proven to be just another method, just another way of being able to ensure healthy children, but a really important way, and a way that we didn't have until recently when the cost of sequencing came down.
And another way to read and find other possible cures or treatments, but you need that information for the other diseases, right?
Right. So these are all conditions that we already know have treatments. So we don't even have to do any development of the treatment. We already know exactly what to do for these kids. And so it's simply a matter of knowing that this baby needs it, this one doesn't. This third one down the road, they also need a different one, but we have to be able to see who needs it and what they need, because otherwise, and I have to say, unfortunately, I've been doing this a while, but unfortunately, sometimes I've diagnosed those children with those conditions only after they've died. And that's the tragedy for me, is when we have a child who dies undiagnosed of a treatable condition that if we'd only known, we could have made a world of difference. And that's what we're trying to do. We're trying to prevent those deaths that were unnecessary, or those individuals who had real harm to either life, health, or brain damage as a result of not getting treatment.
Yeah, that is heartbreaking. And I know there's a bill, because we were talking about it today, the Newborn Screening Saves Lives Act. So everybody wants to read up on that. That's good to know about. I'm also, doctors more and more, thankfully, are advocates like yourself. And you not only know the science and everything else, now you have to worry about your funding and grants and so much that has happened in the past year, and before, that the way science is changing. Like, for example, Dr. Francis Collins, his BioLogos Foundation that he started, it's now, he's trying to push science is good and change the way people feel about science, because things have been coming at science so negatively. And to get back to what you're talking about, and what you advocate about, how do we get there in all those things, in education and research investment and healthcare access that you started out talking about?
I think it's understandable. The science is complicated. It's even for me as a doctor and as a scientist, there's some areas of science that I don't do all the time, and it's complicated even for people like me. So I think the important thing is for us to be able to communicate better and more often. And that's actually why I'm here today, is to be able to help, I hope, make this more understandable and to understand the why. I think once you understand the logic in terms of why we do some of the things we do, or why they take so long, or why they're so hard, I hope it's easier to understand why we do things. And I'll be honest, in science, we don't know the outcome in advance most of the time. So we have to do trial and error. We don't always know what's going to work or what's not. But you have to have an open mind. And importantly, I think one of the things that scientists have not done as good a job at is understanding what's important to the people we're trying to partner with. So in other words, patients and their families, what's important to them, what's their research agenda, how do we help them on their journey as they're going forward to be able to think about what assets we have, what levers we can pull, what are probable and possible things to be able to do. But it's really by taking their agenda in terms of what are the gaps we need to fill. And that in a good way changes. It changes because we take care of one thing and there's something else that comes up. And so we move on and we take care of the next thing down the road. And sometimes we're lucky and we can connect the dots, and we can take what we've learned from one patient or one condition, and we can apply it to someone else. And I hope, I truly, truly hope that one of the eras we're coming into is to see success stories like cystic fibrosis, spinal muscular atrophy. There are a few conditions, sickle cell anemia, a few conditions that are the more common rare conditions where we're starting to get traction. And the question is, how many times can we rinse and repeat and be able to figure out the lessons learned and apply them to some of the other conditions that may not be as common, and to be able to do this faster, less expensively, but just as effectively. And so I think in the rare disease community, we're trying to think about, as I said, lessons learned and applications about what we've learned from one condition and apply it to another condition. And I'm really very excited that there are some platforms and new technologies that I think are sometime in the next decade, I'm not going to say exactly when, but sometime in the next decade really going to be transformational for at least some of these conditions.
That is exciting. And are you worried at all that some of it has been stifled because of funding that's been pulled, or, attitudes?
Well, I'll be honest, there's sort of pressures that are coming from multiple directions. So there are pressures in terms of, because the conditions are so rare, companies don't want to invest in rare. They say, there's not a market for this. There's not enough money to be made, given the enormous cost we have to bear to be able to get a treatment to go forward and to get regulatory approval, get FDA approval. And I understand that. I understand how expensive it is because you have to do it safely, and you want to make sure it's effective. So that's one lever that becomes harder. We then use the federal government, oftentimes the FDA, the NIH, to be able to fund things. And, whenever there's a cut in the federal budget or change in direction or change in prioritization, there are oftentimes not many researchers in the community that study that rare disease. And all you have to do is knock that one critical person off their course. And if you lose them as an asset to the community, you may lose like all of that wisdom and experience they've accumulated. And it's really a community resource, a community asset. And I hate losing that. And I will say there are a lot of individuals, most of the researchers doing this type of research, they're not living the life of glory. They're not rolling in the dough. They're just incredibly mission-driven people that are just kind and caring. And some of them, I will say, are getting discouraged. They're getting worried in terms of, are they going to be able to continue the funding, doing what they're doing? Are they going to have to, find another job, find another profession because they can't be able to get the type of grant funding going forward? And if we lose too many of those people from the community, we're going to lose lifelong what I fear are some real insights that are going to get us towards treatment. So it's a tough time for scientists and for science.
I think so, too. When I was in D.C. advocating, there were scientists carrying signs that said I'd rather be in my lab, but they were all fired, so they were out there with pickets. And then every time I meet someone, we toured the newborn screening lab in Lansing, Michigan here, and it was so interesting. For 2 hours, science talk. It was so cool. I'm not that smart, but it was great to be around scientists and just hear that newborn screening, the minute blood drop that you use to detect things like cystic fibrosis and other, it's unbelievable. And you hold on to those dried blood spots for like 35 years in Michigan. And, anyways, it's just so cool. And then I was watching this stream with Bill Gates, and he said, we were talking about vaccine hesitancy, which I wanted to get into because of the shooting that happened today against somebody who's disgruntled about vaccines at the CDC. Very tragic and sad, but it's about vaccine hesitancy. And Bill Gates was saying, if the United States is hesitant, then developing countries will be more hesitant, and more people will die there than in the United States because if we lose confidence, then they have lost confidence. So if you can address that, it's just this downward spiral of, how do we get confidence back? There's so much misinformation.
Yeah.
It's hard to just keep saying, no, read this. It's not true.
Like you said, in this day and age, there's a lot of information coming from us from many different sources. And sometimes it's even hard to know which sources are fake and which ones are reliable. And it's hard to vet all of that. And especially if it's something that's not your area of expertise, it's really hard to know what's the truth, what's, reliable information, what's not. I will say, and again, as a pediatrician, vaccines are one of the most important things for children's health because they help us in so many ways, whether it's preventing measles, mumps, rubella, even the flu every year, especially for children and the elderly. Both the young and the old and the disabled are very vulnerable to these infectious conditions. And with that, it has saved literally thousands and thousands of lives every year from something very, very simple. And I know people, I also study autism, and so I also know that people are worried in terms of will it increase my child's risk of autism, or for individuals who have a child with autism, they're constantly racking their brains, or what did I do? What could I have done? I say this in talking with a lot of especially mothers who carry the sense of guilt that there was something that they missed or should have done or could have done or did do that caused their child's autism. And if there are any of those moms out there listening, I just want to reassure you that, number one, vaccines do not cause autism. One of the original papers that sort of started that unfortunately misinformation was actually retracted. It was by a scientist, a physician, that actually it was not a valid study. It was not a study that was done well and was retracted. So there have been many other studies done since, and many vaccines that are very safe and very effective. But I understand where people come up with the notion. They see that the number of vaccines has increased over time. They see that the frequency of autism has increased over time. And so they make the leap and they say, well, these things both are going up at the same time. One must be causing the other. But, you could say lots of other things have changed over time. Cell phone usage has changed over time. I don't hear as many people saying that cell phones are causing autism. So, in other words, correlation does not equal causation in terms of this. But like I said, I think people, when there's a question of why, they search for that. They really do search to honestly try and understand the world around them and come up with a story that makes sense to them. I just wish that, there were a way of being able to correct misinformation and to be able to, look at the data and be able to assess the data. But I can tell you, as someone who looks at data all the time, there is no data to suggest that, or data to support that vaccines cause autism.
And sticking with autism, because I often think, okay, well, we know that there's a defective gene in cystic fibrosis. So we know kind of what causes CF. So having that information is very helpful as a parent, right? I also know that nothing I did caused my daughters to have cystic fibrosis. Joe and I didn't know. So that's also a comfort. But with autism, because I wonder, like nothing else, it's people are just so exactly what you said, want to blame something about autism. How do we help that? And when do you think, or why do you think we don't have an answer? I mean, RFK Jr., health secretary, promises he'll know why, in September. But what hope do you have or see for, parents who maybe want more answers like we have in CF?
So, autism is not one condition. It's called a spectrum because it is a spectrum. And within this, there's not just one cause, there are multiple causes. I will say that a significant portion is genetics. It's not all genetic, but notice that I said genetics because there's more than one gene that's involved. We already know of over 200 different genes that cause autism, and we know we haven't identified all of them yet at this point. And we can say that we know that genetic is a significant component based on twin studies. When we look at identical twins, if one twin has autism, almost all the time the other twin has autism. Not 100%, but most of the time. Whereas fraternal twins, same-sex fraternal twins, much lower what we call concordance, or likelihood if one twin has autism that the other twin has autism. And of course, for twins, they share the same intrauterine environments. They usually share the same home, the same home environment after birth, but the genes are really what's different. So that's what helps us point to the genes and then actually identifying those genes. But there may be other causes. Prematurity, as an example, increases the probability of autism. We know of some prenatal infections that increase the chance of autism, and even sometimes postnatal, after the baby's born, some types of infections. So we know there are various different things that can affect the brain and development, and when it affects the brain's development, it affects the brain's long-term function as well. So it's complicated. And some individuals, it may not be a strict, clean answer that we see, and parents are still left with the why question. And I know it's haunting. And so you search, as I said, to be able to fill that void, to understand and to understand the world around you. And for some women, they're also thinking about having other children, and so they're desperately trying to make sure that they can do everything they can to have a healthy child, and for understandable reasons. Therefore, they're searching for that why. And I guess one thing I've learned in life is we don't always have all the answers. We search,
Right.
and we really try and do our best to do it in the best way we can, but we don't always know the answers.
And, in regard to vaccines, I always think people don't need to go back in time to see how much people in the 1500s would have begged for vaccines. They really don't. They can go to a developing country and see it. They can see
that's true.
how, they're dying without the vaccines, basic vaccines, or how they weren't getting, vaccinated for various illnesses. It's right there. Like, I just wish those that needed that, we could just put everybody on a plane. You could see what's really happening and then bring them all back, because the evidence is so right there and clear, that these will save your lives and give you a long life. Are you finding with the people you serve that there still is confidence in vaccines?
Well, I mean, I think, different communities, different families have different beliefs in this. To a certain extent, there's been what we call herd immunity. That is that if most of the people, I don't mean that people are herds, or
Right.
animals, but the idea being that if most people in the community are vaccinated, there's not a very high prevalence of the virus or whatever the infection is.
Like measles used to be, right?
Exactly.
Until we stopped vaccinating, I guess.
So, there was a time when you could kind of get away if yours was the only child in the class that didn't get vaccinated. Everyone else was kind of taking it for you, and your child was okay. But we're breaking below those levels of that herd immunity in many cases. And that's why we're seeing some of the outbreaks that we are. And unfortunately, what I worry about is as we lower that percentage of people vaccinated, poof, it's really going to potentially explode.
So I know we were going to talk about some other things that you had written about, and exploring alternative funding models and things to keep science going. Did you want to touch on that, the direction of where you would like to see that go?
Sure. So I think there are a couple ways. I work really closely with our patients and families within the rare disease community. And I guess one thing I'd like to invite the community to do is that we've got to work together. We've got to stick together. We've got to work together. You as patients or families have to help us understand what's important to you so that we're pointed in the right direction in terms of the problems we're solving. And increasingly, I'm always excited about all of the assets that we've got in the community. Many of our patients and families have their own superpowers, I call them, but everything from ability to communicate, ability to communicate to others, the public, communicate amongst each other, spread the information. Some people are really good at technical things. I mean, I'm not so good at a lot of tech things, but other people are. Some people really are good scientists. Some people are great nurses. Some people are great people in terms of organizing skills, and they're just super organized. But you put all of these people together and divide and conquer. And in some cases, some people who have the ability to fundraise for the funds that we need to do it, but you do this together. And as I was saying, you don't have to do this 7,000 times for 7,000 rare diseases. There's an economy of scale. So as you're doing this across the rare disease community, the first is hard, the second is much easier, and the third, I won't say it's easy peasy lemon squeezy, but it's so much easier as you start doing it over and over again. And so I think if we collectively work together, we're going to get there much faster and more effectively. Like I said, I learned so much from the others in our community that they teach me things every day, and that's why I keep doing what I'm doing, because they make us smarter, better, faster. And as we do this, we're trying to be careful about resources, especially when there are funding constraints in this current environment.
And that is great advice. And it kind of gets to advocacy. I mean, they need to keep you in touch, or families like mine need to keep their, clinics and doctors and staff and social workers and everybody kind of in touch with things important to us, as you just said. But how do you think advocacy is going, or how do you encourage people to advocate in different ways, either for science or in addition to maybe their families?
I'll say right now, being able to have your voice heard. So at the federal level with the federal budget, in terms of your congressperson, your representative, the NIH budget, and being able to advocate for science at the National Institute of Health, the National Science Foundation, the Center for Disease Control. The Congress is deciding how the dollars will be spent, and it's important to raise your voice now and be able to say science matters, science saves lives. Don't leave us behind in terms of making sure that the science that we need for our communities continues to live on. So literally, write your congressperson, call your senator, let them know that. That's probably one of the most important things you can do exactly at this moment as we're going forward. And then, of course, within your community, make sure that, again, your voice is heard in terms of this type of questions that matter. What's important to you? What are the gaps that we need to fill as scientists, as physicians, to partner with you, but make sure we're pointed in the right direction.
Well, and I think that's a really inspirational way to end this podcast, but I want to make sure that if there was anything you wanted to say that maybe I haven't asked you about, would be a good time for you to mention it as well.
I just want to thank you, Laura, for what you're doing. It's so important to be able to partner together on this, and I feel privileged to spend a few minutes with you.
Well, thank you so much, because you've had a long day of doctoring and now you're doing this podcast with me. So I really appreciate your time and all the information and your knowledge. And thanks for doing what you're doing. Appreciate having you.
Yeah, thanks for having me too. Take care.
The original music in this podcast is performed by Kevin Allen.
It's not complicated.
Who happens to have cystic fibrosis.
We all got our worries and fears. I know it's got you frustrated, but loving you is so alright.
This has been the Living with Cystic Fibrosis podcast. For more information and to learn more about the Bonnell Foundation, visit our website at thebonnellfoundation.org. That's the BONNELL Foundation.org. This podcast was sponsored by Vertex Pharmaceutical, The Science of Possibility, and Viatris. It was produced by Jag and Detroit Podcasts. Follow our show in Apple Podcasts, Spotify, or wherever you're listening right now.